Well, first of all, I want to thank everybody. I think it was just it was a terrific day. I think we learned a lot. Um, and it was particularly striking how little caffeine and that adolescents and children drink, and how few energy drinks that children drink that aren't either by mistake or some form of abuse. Um, I did want to clarify one issue, and that is in terms of the deaths. There are, as you know, several deaths in the FDA AERs. The FDA themselves have said that that doesn't mean cause and effect. And as you know, there have been 2 lawsuits launched at Monster Energy. One is that of I mean, these are terrible cases. You know, as a parent, just thinking about these children is something that just completely tears you apart. One of them was a 14-year-old girl. This girl had myocarditis. And it's very important for those electrophysiologists and cardiologists in the audience that even if you go to the myocarditis site, you'll see that there is no link between caffeine or other stimulants and sudden death and myocarditis. It's a very tragic condition, takes a number of lives every year, but there is no link. The second case, that of a 19-year-old male, in this particular case, he had cardiomyopathy. His lawyer had alleged that over 3 years of drinking energy drinks, roughly 320 milligrams a day, that there had been a cause and effect there. And again, for the cardiologist in the audience and the pediatric cardiologist, there is no cause and effect. That is, he had other risk factors for cardiomyopathy, but energy drinks and caffeine do not cause and effect. You know, we're all very concerned. We think that this is a terrific conference. We really have looked at a lot of wonderful issues here. And I just want to again thank you very much for your time, attention, effort, and just a spectacular effort on the behalf of the IOM. Thank you.
Thank you so much for your comments. Okay, our next speaker is Joel Gerling. Hello, thank you.
Hi, my name is Joel Geerling. I'm a neurologist in Boston. I'm also a lab scientist. I study the circuits that help keep us awake. I've followed the controversies in the literature regarding caffeine and energy drinks for a number of years now, partly because many friends and colleagues and patients have questions about it, and in large part because I consume energy drinks myself. I switched from coffee a number of years ago because personal preference, and also I like the moderate, consistent amount of caffeine that's in the cans as compared to coffee that you get from a coffee shop. I guess part of the reason that I'm here is a kind of disappointment with a lot of the things I've seen in the, in the literature, even in good journals, even in good peer-reviewed journals, clinical journals. I've just seen some exaggerations and, in some cases, I think misstatements that have passed peer review. For example, an article published in Pediatrics just a couple of years ago, the authors stated that some children were at increased risk for cardiac arrhythmias and sudden death from caffeine-containing products, and they cited 3 articles, 2 of which were about prenatal exposure to cocaine, and one of which was about the ethics of treating patients with cardiomyopathies in children, and none of those contain the word caffeine. So I found that a little worrisome, and I guess what I would urge the board to consider is the content and the quality of the evidence that we're talking about. So we've heard a lot today about behavioral survey data and some very interesting basic neurobiology, but one thing that no one mentioned was the largest randomized controlled trial of caffeine administration to infants and children and the favorable neurobehavioral outcomes from that trial. Also, many randomized controlled trials that have been conducted with intravenous caffeine looking at seizure outcomes and the lack of seizures that are caused by that. These things frequently don't get mentioned. And so I would just urge the board to consider the quality and the content, the level of evidence, as we say in clinical medicine, when evaluating these things regarding the safety of caffeine.
Thank you very much. Thank you for that. Okay. Next, I have John Higgins. Did you ask?
Thank you very much. I'm deliberately putting on my doctor's lab coat here because I'm now speaking to you as a physician. And as a physician, You know, when we take our code of ethics, one of the things we say is first, do no harm. And I know that you all know that there have been issues associated with these energy beverages. In some countries, they have already been banned altogether. In other countries, they have banned their sales for those under 18. I believe that these energy beverages are different to coffee. I think if coffee was dangerous the way energy beverages is or are, coffee's been around for a long time, I think we would have seen more issues with coffee. And caffeine itself, pure caffeine, also seems to have a different effect. Pure caffeine by itself it's a different beast. Pardon the pun, you know, it is called Monster, one of the energy beverages, but it is a different beast to coffee. So I think what we need to, as a group, ask ourselves is if we are to first do no harm to those who are vulnerable, we've got to ask ourselves who are the vulnerable individuals. And we just heard about a case described by the Monster folks about the 14-year-old girl, and I may be mistaken, but I understood she had actually the diagnosis of Ehlers-Danlos syndrome and not myocarditis. However, I would like to say that even if it's a small percentage of children and adolescents who are vulnerable for whatever reason, whether it be they get more addicted, whether they have more cardiovascular effects, or whether it leads to them taking more risk behavior or consuming other materials that are risky, we should ask ourselves, even if it's a small number, a handful, and as I mentioned, the deaths that I'm aware of associated with energy beverages are between those who are aged 12 and 19 years of age. Then why not, as a society, not only of physicians, but also of caring adults out there, some of whom have children in this vulnerable population, ask ourselves, can we at least protect this vulnerable group and consider doing what others have done and restrict at least this vulnerable population from running into problems with these particular products or high levels of caffeine. And so I would ask you to think about that today, and if you're going home tonight to see your teenagers or youngsters, ask yourself, do you want them to be in a situation in the future where they are consuming these beverages and you may not know whether or not they will have a serious adverse event or not? And thank you for your time today.
Thank you very much. And the next speaker is Rick Kingston from Safety Call International. Good afternoon.
My name is Rick Kingston, and I'm with the Safety Call International Poison Center in the University of Minnesota. My comments relate to poison control adverse event data presented here today and also submitted to the committee in the form of a recent publication in the journal Clinical Toxicology. In the published article providing a breakdown of the 1,480 non-alcoholic energy drink exposures when tabulating the outcomes for all age groups, but especially for the less than 12-year-old populations, it's disappointing that two of the most important outcome categories in the entire database, the asymptomatic outcomes of no follow-up non-toxic and no follow-up not more than minor effects possible, were left out of the data presentation. When including these outcomes for the non-alcoholic energy drink exposures that involve children less than 6 years of age, although they had the highest exposure rate, it demonstrates that they also had the lowest incidence of any adverse effects, including the fact that there were no serious outcomes. In fact, 85% of the cases were either non-toxic in nature or resulted in no adverse consequences. In those cases where adverse effects were reported, almost all were minor in nature. When including 6 to 12-year-old populations, the non-toxic events were still greater than 80% and serious outcomes were rare. Leaving out these two outcome categories distorts the denominator and exaggerates the overall relative percentage of adverse effects in all populations. A more meaningful statistic would be to highlight the average age of all symptomatic exposures, which would likely demonstrate that older teens and adults are the target populations for risk mitigation efforts. For the 13 to 20-year-old populations, which incidentally is straddling both underage teens and legal adults, as well as targeted and non-targeted markets, The overall numbers of incidents were extremely low, considering the ubiquitous availability of products. Even for the 249 cases tabulated, serious outcomes appear to be uncommon within the reported incidents. Regarding serious outcomes for all populations, the data appears to suggest that serious outcomes are uncommon in all populations under any circumstances. So notwithstanding the possibility of coding errors, lack of incident confirmation, and even anonymous reporting, 7 major effects is small. It's further disappointing that virtually no incident details were provided for the 7 cases, such as an indication of which products may have been involved, formulation characteristics, doses of caffeine producing the reported effects, and investigation of other factors potentially contributing to reported adverse effects. Lastly, for the data presented today by Dr. Bronstein, I pointed out earlier that an important distinction for unintended exposures in children less than 12 was omitted from the conclusion, and that is that more than 80% of exposures resulting from unintended events in this population do not result in any reported adverse effects. A positive and important message from the presentation is that more focused post-market surveillance is needed to define which products and formulations do give rise to adverse effects, especially in those populations routinely consuming various products. This will certainly help focus injury prevention methods for the appropriate populations. Thank you very much.
Thank you very much. I next have Amelia Leonardo from the Grocery Manufacturers Association. Hello.
Good afternoon. I am Dr. Amelia Leonardo, Vice President of Consumer Product Safety and Science Policy at the Grocery Manufacturers Association. GMA represents the world's leading food, beverage, and consumer product companies. Our members are committed to providing consumers with safe, wholesome, quality products. Caffeine has been part of the human diet for centuries. It is a safe, naturally occurring substance found in leaves, seeds, or fruits of more than 60 plants, many of which are staples in our diets. In addition to its natural presence in commonly consumed foods, caffeine is used as a food ingredient. Caffeine safety has been extensively studied, and more than 140 regulatory agencies throughout the world consider the appropriate use of caffeine in food to be safe. GMA encourages this committee to review the data and build your determination on sound, evidence-based science. Our industry looks forward to working with FDA on enhancing label information on caffeinated products so that consumers are more aware of the caffeine content in the products they enjoy. In addition, we will collaborate with FDA on developing a guidance document that sets appropriate boundaries on the addition of caffeine to food products that is based on sound scientific evidence and in the best interest of public health. Thank you.
Thank you very much. Our next speaker is Ren Almondhiri from CRN. I'm sorry, I don't have it spelled out what CRN is. I apologize.
Hi, everyone. I'm Ren Almondhiri. I am Regulatory Counsel with the Council for Responsible Nutrition. We are a trade association here in DC, and we represent dietary supplement manufacturers and dietary ingredient suppliers. So I'm an attorney. I'm not a scientist or a medical doctor. So I found all of this very interesting and very informative. So I just want to thank FDA and IOM for putting this on. CRN encourages balanced, robust discussions on caffeine and continued research on caffeine from all sources and its potential effects on vulnerable populations and the examination of any data gaps. We think these play an important role because any decision-making or future policies and regulation in this area should always be based on sound science. We know caffeine is widely consumed and well-studied and safe for most people. But we also recognize the role of industry in ensuring safe products and the importance of transparency for consumers, and especially parents, so they can make decisions for their family. And CRN also believes that safety is paramount. We support the current regulatory framework that we believe helps promote safe dietary supplement products, including those with caffeine. And safety begins at the manufacturing level with GMPs that help assure quality products that meet label claims. And then manufacturers are also required by law to ensure products are safe before they are sold and labeled appropriately. And then finally, we support mandatory adverse event reporting, which we think is an effective and important way to monitor safety post-market. And just briefly, I want to mention the role of self-regulation, such as the CRN recommended labeling guidelines for dietary supplements that contain caffeine. These inform consumers and, most important, parents about the amount of caffeine in a particular supplement, and also alerts those with health conditions or sensitive to caffeine about its presence in a product. These encourage a dialogue between healthcare professionals and patients, as we know individual tolerances can vary widely. And in closing, once again, CRN supports the type of dialogue that we are having today, which we think helps promote the safe use of caffeine, and we encourage public policy decisions based in sound science, and we look forward to working with FDA as well on any future guidance documents for these products. Thank you.
Thank you very much. Next commenter is Phil Saul from Patton Boggs LLC.
Thank you. You've given me sort of a new job. I'm a pediatric cardiologist at the Medical University of South Carolina, but
Never mind.
I am here today for the American Beverage Association as a consultant, but I'm not really here to argue for or against energy drinks. What I wanted to do today was just, as a pediatrician, as a pediatric cardiologist, and as a parent, tell you what I do in my practice with caffeine. And I sort of divided into three categories. The first is kids under 12. I think most of the people in this room do not recommend caffeine for their kids, for their grandkids, for their patients under the age of 12, and in the form of beverages. We don't usually restrict it in chocolate. If I have a patient who's between 12 and 18 years of age and has a condition in which I'm worried about caffeine, and the three main ones are arrhythmias. I think Jeff Goldberger did a great job of saying that as physicians, we're not really following an evidence-based guideline for that. In fact, the evidence suggests that most arrhythmias aren't exacerbated by caffeine, but we know that some are. And so almost all of us, and I do the same thing, will tell patients who have arrhythmias to avoid caffeinated beverages. The second is syncope. So it turns out that benign syncope is often exacerbated by caffeine, and that's another condition in which I ask my patients not to use caffeine. I do have them withdraw slowly because of my own experience if they're on it. And then the third one is any kind of significant cardiomyopathy. So if you have significant cardiac dysfunction, then those patients I usually recommend that they don't have caffeine. Other than that, between 12 and 18, I'm usually querying patients about what types of caffeine they intake, and I have to give them the list of the names, Mountain Dew, iced tea, energy drinks, et cetera, because a lot of patients between 12 and 18 simply don't know when you say, do you drink caffeinated beverages? And my experience is that energy drinks almost never come up. My experience is much more like the NHANES data, that what patients tell me they're drinking, at least in South Carolina, where I'm from, is sweet tea and Mountain Dew. Occasionally Pepsi Cola, it depends. So those are the things that and generally, for any patient, I recommend that they use it in moderation. And for moderation, what I've learned from today and from reading a lot of the literature basically means 3 to 5 milligrams per kilogram per day maximum. So 2 to 3 servings of 1 to 1.5 milligrams per kilogram. And for the most part, there are no cardiovascular effects that I know of. I went through earlier, and I'll address slightly again the sudden deaths. But so for me, that's a safe issue. And it also looks like the data really suggests that what's happened is energy drinks have replaced other forms of caffeine in the diet over the last few years, although I'm not seeing that as much. So finally, I'll just speak for a minute about the sudden deaths. Almost everyone who dies suddenly in adolescence has an underlying heart disease. We can't always identify it. These are not genetic polymorphisms. They are genetic abnormalities. So it's long QT syndrome, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, catecholaminergic polymorphic VT. And we would think those would be sensitive to caffeine and stimulants, but as far as we can tell, stimulants don't seem to play a big role, and we don't really have the data to say about caffeine, but it certainly is used a lot in public. Thank you very much.
Thank you very much. And the next speaker is Daniel Steffen, and I'll let you announce who you're with. Not present? Okay, next we have John White.
Hello, my name is John White, and I'm a professor from Washington State University, and my area of interest is kinetics, and it's a total surprise that my name's on that list, so this has been a very interesting meeting. I guess I'll make a couple of points. Since I'm a kineticist, you'll probably be asleep by the time I'm finished. There was a point made earlier today regarding the input of caffeine, rapid intake versus slow intake, and it was suggested that a problem with energy drinks results from the idea that you can drink them rapidly. And it turns out if you look at the kinetics of caffeine, if you look at the time of absorption, if you look at the half-life, you look at the volume of distribution, intake time is only of nominal consequence with regards to peak concentrations. And I say this based on having actually run some models looking at intravenous input versus a slow input of 45 minutes versus a rapid input of 5 minutes. Peak concentrations are essentially the same in those three scenarios. Last thing I wanted to say, as a kineticist, I shouldn't comment on the behavioral studies, but I've got to say this. My guess is that if we came to my university, Washington State University, and we did a survey of risky behavior, we'd probably find a correlation between nose rings and tattoos and risky behavior. Now, I don't believe we could ban nose rings and tattoos and say that there was a causal relationship there. And I think a similar line of thinking could apply to the last study that was very eloquently presented. I just don't believe there can be, or there is enough data to suggest a causal relationship between consumption of energy drinks and progression to use of more addictive drugs. So,
I hate to ask a comment or a question, but in terms of kinetics, have you looked at whether people are slow or rapid metabolizers in that regard?
no, and that's a good question. And in the modeling that I did, I used literature means. So, and there would certainly be differences with differences in 1A2 metabolic capacity. And I'll finish by saying that there aren't good studies comparing rapid consumption and slow consumption and cold beverage consumption versus hot beverage consumption.
Thank you for your comments. Richard, Dick, do you want to come up now? You're
Thank you, Lynn. And actually, John made a point I was going to, so I'll eliminate that. I want to talk about two things. One is coffee, and the second one is the other ingredients in energy drinks. And I was going to save that for tomorrow, but since there's not public comment, I'll make it now. Coffee, it was alluded to just briefly in one talk, but coffee has over 1,000 compounds in it, over 1,000 compounds. In both the roasted bean and in brewed coffee. And caffeine is not the most abundant compound in coffee. So we all should remember when we're dealing with energy drinks, which generally have 4 or 5 ingredients, coffee has over 1,000 ingredients. The chlorogenic acid is much more percentage-wise in coffee than caffeine is. Trichonelline is. Total peptides are. Total carbohydrates are. So coffee, it consists of a mixture of compounds. If you want to deal with mixtures, just have coffee. The second thing is energy drinks basically are caffeine, taurine or another amino acid, carbohydrates, generally either glucose or sucrose or glucose fructose or high fructose corn syrup, sometimes gluranolactone, and sometimes herbs. The amounts of these compounds in energy drinks, there is very little evidence that they are there with regards to any adverse effects at all from anything. And caffeine is the energy in energy drinks unless it also has a carbohydrate in. Certainly, the only central component, central stimulant that you're getting is from caffeine. Lastly, taurine has been looked at, and gluranolactone has been looked at several times by another regulatory authority, the European Food Safety Authority, and they have come up with a NOEL in animals for both these compounds, which is 1,000 milligrams per kilogram. 1,000 milligrams per kilogram. And the safe level that they say for taurine in humans is 100 milligrams per kilogram. Thank you very much.
Thank you. We have still a few more minutes in the public comment session. Are there others who had wished to give comments who hadn't signed up and would like to make a comment now? Okay, that being the case, I am now going to adjourn this meeting for today. We're getting back together again tomorrow morning. Please return. We'll see you in the morning.